So thank you, Dr. Stats, and thank you for inviting me here to present this work. I was just recently awarded a CFAR small grant, so that study just started enrollment. We don't yet have any preliminary data, so I'm really going to be talking about the study that informed that grant. And it's a study that I started as a global health fellow in Botswana, and it's focused on pneumonia outcomes in a specific group of children referred to as HIV-exposed uninfected. So as many of you know, Botswana is among the countries most affected by the HIV epidemic. Among pregnant women, the prevalence of HIV has been hovering around 33% for the past 5 or 6 years. But one of the great success stories in Botswana has been their program to prevent mother-to-child transmission. So since this program started in 1999, the mother-to-child transmission rate has dropped from 21% to less than 2%, making it really on par with the lowest transmission rate in Southern Africa. And so currently in Botswana, the situation is that you have a continued high prevalence of HIV among pregnant women and a very low rate of mother-to-child transmission. And the result is that roughly 30% of infants born in the country are born to HIV-infected mothers, but do not themselves acquire the virus. And it's that category of infants that are referred to as HIV-exposed but uninfected. HIV-exposed uninfected infants have 2 to 4 times higher mortality in African settings than the children of HIV-negative mothers, and those kids are referred to as unexposed. And you can see here, this is data from 6 sub-Saharan African countries, and the percent mortality of HIV-exposed uninfected children is shown in light gray, and you can see that it generally exceeds the percent mortality that is seen for unexposed children. Where I've done most of my work, Botswana is shown on the far left, and in that country, exposed uninfected infants are a full 4 times more likely to die before their 2nd birthday than the children of HIV-negative mothers. Not surprisingly, much of this excess mortality appears to be related to infections, and in particular, lower respiratory infections. So why are these infants at risk for poor health outcomes? It's probably multifactorial. Certainly, infant feeding practices could be playing a role. HIV-infected mothers may either be less able to breastfeed because of illness or may choose not to breastfeed to reduce the risk of HIV transmission to their infants. HIV-infected mothers may just be physically less able to care for their infants because of illness or death. Certainly, exposed uninfected infants living in a household with an HIV-infected mother may be more likely to be exposed to infections like tuberculosis. Socioeconomic factors could play a role. But what is also underappreciated are well-described immune abnormalities that exist in these infants. So these are abnormalities that are present at birth, are of both the adaptive and innate immune systems, and that really seem to result from both exposure to the HIV virus itself or perhaps the chronically activated maternal immune system, as well as to antiretroviral medications that mothers receive during the pregnancy. So the objectives of our study were first to compare pneumonia outcomes in HIV-exposed, uninfected, and unexposed infants in Botswana. And then secondly, we're really aiming to identify the potential mediators of that HIV exposure to outcome relationship. And I'm just going to present some very early results that we have for that secondary objective. So the study that we conducted to look at this was a prospective cohort study. It was conducted at a single referral hospital in Botswana, in the capital and largest city, Gaborone. It ran from April 2012 to June 2016. And what we did is we recruited children within 6 hours of their arrival to the hospital and then followed them daily until hospital discharge or death. Our primary outcome is a composite outcome variable, which is termed treatment failure, which was assessed at 48 hours after the child's triage time. And importantly, this is an observational study. So these kids receive standard medical care. All antibiotic decisions and all other aspects of the child's care were really at the discretion of the treating pediatrician. This shows our data collection procedures in a little bit more detail. So within 6 hours of arrival to the hospital, we obtained written informed consent from a legal guardian, and then we gathered enrollment data from a number of sources, caregiver questionnaire, a physical exam of the infant, We've reviewed both infant and maternal medical records, and then we collected a number of specimens for microbiological testing, a nasopharyngeal swab specimen, a whole blood sample, and a serum specimen. And unfortunately, I'm not going to talk about any of the microbiological data today. We followed kids. Typically, they were admitted to the hospital. We followed them daily while they were admitted. Our primary outcome was assessed at 48 hours, and then again, we followed them until they were discharged or died. Children were eligible if they were less than 2 years of age, and we really chose to focus on that narrow age range because that's the age during which HIV exposure has been shown to have such a profound effect on child mortality. And the second inclusion criteria is that they met WHO clinical criteria for pneumonia. We had a number of exclusions. We excluded kids who had other chronic conditions or chronic conditions that predisposed to pneumonia other than HIV. Children who had been recently hospitalized, children who had asthma or whose respiratory distress resolved with bronchodilator treatment, and children who had also been recently enrolled in the study. We classified children as being HIV unexposed if their mother tested negative for HIV during the pregnancy, at delivery, or at enrollment. And then our exposed uninfected group consisted of infants whose mothers tested positive for HIV before or at the time of delivery, and then the infant tested negative for HIV by a DNA PCR performed either at enrollment, at least 6 weeks of age if the infant had been exclusively formula fed from birth, or at least 6 weeks after breastfeeding cessation if the child received any breast milk. And in our study, importantly, close to 80% of our exposed uninfected kids actually had an HIV PCR at the time of enrollment that was negative. This is our primary outcome. So again, a composite outcome variable termed treatment failure assessed at 48 hours after the time of the child's arrival to the hospital. And you can see that kids were considered to have failed treatment if they had ongoing lower chest wall indrawing, if they had the appearance of new WHO-defined danger signs, if they were hypoxic on room air, continued to require CPAP or mechanical ventilation, or obviously if they had died during that 48-hour period. And most importantly, this outcome was assessed by a physician or nurse who was blinded to the child's enrollment data, so had no knowledge of the child's HIV exposure status. For our analyses, we used Cox proportional hazards to estimate risk ratios for treatment failure and in-hospital mortality according to HIV exposure status. And all of these analyses were adjusted for age and proximity to healthcare services, which we had identified as potential confounders based on a literature review. Moving on now to the actual study population. So this flow chart shows the number of children we screened and enrolled during the study period. We screened in total 869 children. We had 169 children who did not meet our inclusion criteria. We excluded 253 children, and that left 420 children who were eligible for the study. We had 22 legal guardians who declined consent, and we enrolled the remaining 398 children. This is presenting baseline characteristics of the study population by HIV exposure status. I'm obviously drawing your attention to the left two columns, which are unexposed children on the far left and exposed uninfected children in the middle. You can see that it was a relatively large cohort of exposed uninfected children, 112 in total. Just comparing those two groups, exposed uninfected children tended to be younger than unexposed children, although that didn't reach statistical significance. They were more likely to be low birth weight, as is known of infants born to HIV-infected mothers, less likely to be currently breastfed or to have ever breastfed, and had significantly lower levels of maternal education. But importantly, we didn't observe any differences in child nutritional status at the time of enrollment, and there were no significant differences in any of the other measures that we looked at of socioeconomic status in those two groups. We also looked at a number of factors pertaining to the current illness. And again, just focusing on the unexposed and exposed uninfected groups, we found no significant differences in any of these variables. And these were really measures looking at illness duration, severity of illness at the time of presentation. We looked at a number of laboratory parameters and a number of measures that were aimed at care-seeking behavior. So that was one question, is it that HIV-infected mothers live in areas where they have less access to care, and so these children are presenting sicker and presenting after a longer illness course? That did not seem to be the case. And now moving on to our results. So in total, we had 136 infants who were deemed to have failed treatment at 48 hours. That's 34% of the overall population. And you can see that it's strongly associated with HIV exposure status. So 25% of unexposed infants failed treatment, 45% of exposed uninfected infants failed treatment, and 64% of our HIV-infected group failed treatment. And in our multivariable analyses, HIV exposure was associated with a more than 50% increased risk of treatment failure, and HIV infection more than doubled that risk. I think even more impressive is the effect that it has on in-hospital mortality. So these are small numbers. We fortunately had just 6% of the children who died in our study. That's a total of 24 children. But you can see it's, again, strongly related to HIV exposure status. So 2.4% of our HIV unexposed kids, 11.6% of the exposed uninfected group, and a full 15% of the infected group died before hospital discharge. And again, adjusting for potential confounders, HIV exposure increased the risk of in-hospital mortality more than 4-fold, and HIV infection increased that risk more than 5-fold. One thing that we noticed pretty early is that there seems to be a critical time period during which HIV exposure has an effect on outcomes. So we really only see differences in outcomes during the first 6 months of life, so kids who are aged 1 to 5 months. And shown on the right are treatment failure by age in categories of HIV exposure status on the top, and in-hospital mortality by age, again in categories of HIV exposure on the bottom. And again, just comparing the left two groups. So the black bars represent children of all ages, the dark gray bars represent children less than 6 months of age, and the light gray bars represent kids who are older than 6 months of age. Comparing just unexposed and exposed uninfected children, you can see that we saw a very similar rate of treatment failure in kids older than 6 months of age, and the same thing for in-hospital mortality. And it's just in that group less than 6 months where HIV exposure seems to be associated with a higher rate of treatment failure and in-hospital mortality. And in fact, if we limit our analyses just to kids who are less than 6 months of age, we found that HIV exposure increased the risk of treatment failure by 75%, and those kids were a full 10 times more likely to die during the hospitalization than the children of HIV-negative mothers. I'll just quickly point out, not surprisingly, HIV infection increased the risk of treatment failure and in-hospital mortality, really irrespective of age compared to unexposed children. This is something we're very interested, again, in, is we see these strong findings and strong effect of HIV exposure on treatment outcomes. And the next question is, well, why is this? What are potential mediators of this effect? And we're just starting to look at this in our data set. What we've done to this point is assess 5 mediators using Sobel tests. And what's shown in this table is essentially the percent of the total effect of HIV exposure status on treatment failure that's mediated by that variable. And so you can see there are 2 variables that seem to be strong mediators of that effect: reduced breastfeeding and in utero exposure to combination antiretroviral therapy. So that's in comparison to infants whose mothers received either AZT monotherapy or no antiretroviral therapy during the pregnancy. And so certainly we're planning to look at mediators a lot more in this study going forward. This study has limitations. It's conducted at a single center, and it was conducted at a referral hospital, and the capabilities of that hospital don't necessarily reflect what's available in most of Southern Africa. Importantly, we didn't standardize antibiotic treatment. We did record all antibiotic doses, and we compared the antibiotic regimens that were received by exposed, uninfected, and unexposed children. And we found that exposed, uninfected children were treated more broadly. They were more likely to receive a regimen that contained a 3rd-generation cephalosporin and vancomycin than unexposed children. And there is still some potential for misclassification of HIV exposure status. Again, about 80% of our exposed uninfected group were confirmed to be PCR negative at the time of enrollment. Our results are similar if we exclude those kids from these analyses. And importantly, only one of our HIV-exposed uninfected children who died did not have a PCR that was performed at the time of enrollment. So what we've really learned to this point from this study are that exposed uninfected infants have worse outcomes from pneumonia than unexposed infants, but it really seems to be that critical first 6 months of life where we see that association. Reduced breastfeeding and in utero exposure to combination antiretroviral therapy may be important mediators of this effect that we're seeing. And then I think this third point is really important, which is that Botswana has been incredibly successful in eliminating mother-to-child transmission or reducing mother-to-child transmission of HIV. But despite that, in our study, small numbers, but still 3/4 of the pneumonia deaths in our study occurred in children who were either HIV infected or HIV exposed. And so I think that really highlights that further efforts to reduce pneumonia mortality in sub-Saharan Africa are really going to have to continue to focus on those two groups. I want to acknowledge the research team, in particular Colleen Cunningham, who's been my mentor for the study here at Duke. This study was conducted through the Botswana UPenn partnership, and we have another number of other key investigators at other institutions as well. So thank you.
Any questions? Yes?
I actually have two questions. One, what's the combination ART regimen that most mothers are on? And then secondly, what's the Botswana current recommendation in terms of, like, should a mother breastfeed or not?
Yeah, both important questions. So most all of the women received ATRIPLA as the regimen that they received during pregnancy. And then throughout the study period, the Botswana Ministry of Health recommendations for infant feeding were that women were to be screened using AFAS criteria. If they met AFAS criteria, then they were offered free formula through the government. This was an urban study. Most of our population actually did have municipal water, and so I think that's why we saw such a high rate of formula feeding in our population. I do wonder how many of them actually should have been formula feeding versus breastfeeding. There have been some concerns about water in Botswana. So I think that's something that may have played a factor, certainly. Botswana is actually in the process of reevaluating that and may be shifting exclusively to recommendation of breastfeeding in the near future.
Can you comment on the mediation analysis? Does that allow for contributions of factors or
So it's really looking at, I didn't put a diagram up on here, but it's really looking at the percentage of the effect between HIV exposure and the specific outcome that you're looking at that seems to be mediated through that single variable. The analyses I used, we're planning to do more complicated and more sophisticated analyses to really look at those potential mediators, but that's sort of what we're hoping to get is really just to identify which of those potential mediators really could be playing a significant role.